Today we're going to be taking a look at diabetes insipidus, which is a condition which involves reduced levels of ADH circulating through the blood. Before looking at the condition itself, it's important to understand how anti-diuretic hormone or ADH actually functions within the body. So what normally happens is that the hypothalamus produces ADH, and it's then stored in the posterior pituitary gland and released when necessary. This ADH has two main effects, the first being increasing vasoconstriction, where blood vessels constrict to increase blood pressure, and the second being to activate the kidneys, and more specifically, the collecting ducts of the kidneys. And you can see from this diagram that the collecting duct is the end part of the nephron. For this second effect of ADH, we can actually take a closer look at the collecting ducts to see what happens at a more cellular level. So what normally happens is that when ADH binds to its receptor on the collecting ducts, it triggers aquaporin II channels to fuse with the cell surface membrane, thereby allowing water to be reabsorbed from the filtrate into the collecting ducts via these channels. Once inside the collecting duct, these water molecules can be reabsorbed into the blood via channels on the basolateral membrane. And as you can see, the main effect of this process is to increase water reabsorption into the blood and maintain blood pressure. Now that we understand how ADH actually works, we can turn towards diabetes insipidus, which is a condition where there's a decrease in the production of ADH or a decrease in the response to ADH. And this can be divided into cranial diabetes insipidus and nephrogenic diabetes insipidus. For cranial causes, what normally happens is that there's insufficient ADH being produced as a result of a problem to the hypothalamus. And this could be due to brain tumors, head trauma, or infections. What happens during this process is that with less ADH being produced, the aquaporin II channels are unable to bind with the cell surface membrane of the collecting ducts, and therefore water is unable to be reabsorbed into the blood. In cases of nephrogenic diabetes insipidus, there's ADH insensitivity, so ADH is still being produced, but the cells aren't responding to it properly. And this could be as a result of congenital factors, so problems with the aquaporin II channels, or acquired changes such as lithium or other drugs, electrolyte changes, and infections. What happens in this case is that ADH is still being produced, so aquaporin II channels might still fuse with the cell surface membrane, but for example in the case of congenital mutations, this is an impaired aquaporin, and water is still unable to be reabsorbed back into the blood. So as you can see, in both cranial and nephrogenic diabetes insipidus, there's reduced water reabsorption back into the blood, meaning that more water is lost in the urine, and polyuria is often the first symptom which patients complain of. With more water being lost, there's less water present in the blood, and this results in a hypernatremic effect, which is the main electrolyte abnormality seen in the condition. As well as polyuria, patients may also complain of increased thirst, or polydipsia, as well as increased tiredness, or polyphagia, and these three changes form the core symptoms of diabetes insipidus. In terms of the investigations for diabetes insipidus, we can start off by looking at urea and electrolytes, observing for the hypernatremic effect which is explained on the last slide. We can then take this idea further and measure the serum osmolality and urine osmolality, looking for an increased serum osmolality and decreased urine osmolality due to less water reabsorption. And what this basically means is that there's less water in the blood and more water present in the urine, as you can see from the diagram. Alternatively, the gold standard investigation for diabetes insipidus is the water deprivation and desmopressin stimulation test, and we'll look at this in more detail in the next few slides. Once this has been conducted, you can also perform some imaging such as an MRI scan of the brain to look for potential causes of cranial diabetes insipidus. Okay, so taking a closer look at the gold standard investigation for diabetes insipidus, the process involves fluid restricting the patient, and then measuring their starting urine osmolality after around 8 hours. We then administer desmopressin, which is basically ADH, and then we measure the end urine osmolality, comparing both the start and the end to confirm a diagnosis. Let's start by taking a look at the first phase of the test, where we measure urine osmolality after fluid restriction. In a normal test result, we would expect there to be less water present in the urine after fluid restriction, as the body tries to reabsorb more back into the blood. In other words, a high urine osmolality can be used to rule out a diagnosis of diabetes insipidus. In cases of diabetes insipidus itself, there are problems with ADH, so water is still lost in the urine even though you're expecting more to be reabsorbed back into the blood. So if there's a low urine osmolality after water deprivation, less than 400 milliosmoles per kilogram, we might be considering a diabetes insipidus diagnosis, and we should move on to desmopressin testing in this case. Moving on to the second part of the test, we can measure the urine osmolality after administering desmopressin to work out the cause behind the diabetes insipidus. In cases of cranial diabetes insipidus, the problem is due to reduced levels of ADH circulating through the blood. So when we administer desmopressin to these patients, it acts as an ADH analog, allowing aquaporin 2 channels to fuse with the cell surface membrane and for water to re-enter the collecting duct, and therefore the blood. In other words, administering desmopressin in these patients helps to correct the problem, and the urine osmolality returns to normal or high levels. Comparing this with nephrogenic diabetes insipidus, in this case, lack of ADH is not the problem, but rather there's a problem with the aquaporin 2 channels or the collecting ducts. So when we administer desmopressin, or an ADH analog, it does not help to increase water reabsorption back into the blood, and the problem is not fixed. This results in the urine osmolality remaining low after the test. So just to summarize that, in cranial diabetes insipidus, we'd expect the urine osmolality to return to normal levels after desmopressin, whereas in nephrogenic diabetes insipidus, the urine osmolality remains low even after administering desmopressin. The reason why it's so important to find a cause behind diabetes insipidus is that the management is dependent on the cause. So in cases of cranial diabetes insipidus, as I mentioned, there's a problem with ADH production, and we can treat this using desmopressin tablets or nasal spray to artificially increase the levels of ADH back to normal limits. In nephrogenic diabetes insipidus, the problem is with the response to the ADH, and this is a bit harder to treat, but we can try measures such as increasing fluid intake and ensuring a low sodium diet, treating the underlying cause, for example stopping nephrotoxic medications or treating infections, and we can also trial desmopressin at a higher dose, as well as some other diuretics, which might help to rectify some of the symptoms. And here we have a quick summary slide outlining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next one.